Epilepsy Fellow at UCLA and the West LA VA. I'm a second-year fellow. Apologies for the confusion with getting started. I think there was a last-minute schedule change, so the program's a little bit that you probably have is a little bit different. So I'll be giving my talk now, and then I believe Dr. Millett will be giving a talk at noon on the EEG. So the purpose of my talk is to explain a little bit about what is Epilepsy Fellowship, what kind of training do we receive, and how does that differ from kind of what a general neurologist receives, and how is it different to receive care from an epilepsy fellowship trained individual versus someone else. And I'll also talk a little bit about the different levels of epilepsy care. Just to give an overview of my talk, the first part will really be focused on becoming an epileptologist. What is our training path? Why is the training important? And what is some of the curriculum? What are the things we learn about? And then the second part of my talk will focus on delivering epilepsy care or what is the delivery of epilepsy care in the United States. So there are sort of 4 levels that have been described by the NAEC of epilepsy care, and I'll talk a little bit about those. I'll also talk about the VA Epilepsy Centers of Excellence system, or the ECOE system, which is where I do a large part of my training, and then also a little bit about the West LA VA model. So starting with part 1, becoming an epileptologist. So the main message here is it's a long road. It's a very subspecialized training. I'm an adult epilepsy specialist, so I'm doing an adult epileptology fellowship. The timeline is at the bottom. At the bottom of the slide here. So many years of post-baccalaureate training. A lot of us pursue additional degrees. So in addition to what you see on the slide, there might be extra years devoted to pursuing a master's in public health or a PhD. Most of us take 3, sometimes even more board exams. So a lot of studying, a lot of learning. Pediatric epileptologists will take a similar path, but in the slides here where you see adult underlined, they're just doing the pediatric version. So they're doing a pediatric neurology residency and a pediatric epilepsy fellowship. Importantly, cross-training is required, so all adult epileptologists do have some pediatric training, and all pediatric epileptologists do have some adult training. So that epilepsy fellowship portion that I'll be focusing my talk on is really those 1 to 2 final years. I don't know if, are you guys seeing my mouse on the screen or no? Yeah, so it's just those couple of years at the very end that provides that fellowship level of training that I'm focusing on. So I mentioned 1 to 2 years. Is a 2-year fellowship better? Not necessarily. And this, again, is from your perspective. Should you be seeing a 2-year trained fellowship doctor versus a 1-year doctor? It's not the case that 2 years is better. There's some data that shows that EEG interpretation accuracy does not significantly differ between EEGers with 1 or 2 years of fellowship experience. A lot of times fellows will choose to do that additional 2nd year to pursue subspecialized research interests or to gain kind of really deep expertise in a particular area. So it's not necessarily that they're going to be a better doctor for you unless you have that specific thing that they're subspecialized or pursue additional training in. And then the volume matters. So sometimes if you're training, the hospital volume, I mean. So if you're training in a hospital that is very low volume, you might need those 2 years just to see enough cases to really feel competent. But if you're in a very high volume, busy hospital, 1 year might give you more than enough cases to become fully trained. And so a little bit more about why is epilepsy fellowship training important, starting with accurate EEG interpretation. So I think a lot of you probably know what an EEG is, an electroencephalogram. And it's also very important to know that the interpretation of an EEG can be very variable. So there's a lot of data out there that shows that the accuracy of the interpretation of an EEG, so meaning calling something normal or abnormal, can vary a lot among different doctors. And so here's a chart from one of these studies conducted in 2018. And the trick here is that the lower bars are actually represent a higher accuracy, so it's a little bit the opposite of what you'd expect. And so when you compare, for example, on the left-hand side, academic versus private practice neurologists, you see that the academic neurologist are more accurate than the private practice ones. And then when you stratify by years of fellowship training, you also see a similar trend where the more accurate interpreters are going to be the ones with more fellowship training. Then the last two kind of comparison groups are looking at board certification. So these are two of the fellowship level boards that we take for EEG reading. And having the board certification is shown in blue, and again that means lower bar means higher accuracy, so those people are much more accurate than people without that fellowship level board certification. So it's very important to make sure that when you get a test done, the interpretation of it is correct, and fellowship training provides that ability. And then another thing this is another study that showed a similar result. So in 2022, this study was done to look at expertise in reading EEG and how that affects accuracy of EEG interpretation. So here we're looking at experts in blue, experienced readers but not fellowship trained in green, and novice readers in red. And to orient you to the graph, in the top left-hand corner represents a perfect 100% accurate reader. So somebody who has a 100% true positive rate and a 0% false positive rate. And if you kind of look and see where those dots are distributed as far as performance goes, the experts indicated in blue are much closer to that top left-hand corner, indicating that they're significantly more accurate compared to all the other groups of people studied. And the way this study was done, and the way a lot of these studies are done, is basically experts collect EEGs that are both normal and abnormal, and they send them to the doctors in the community and say, evaluate these EEGs, tell me what you think, and they compare their answers to kind of the true diagnosis and see how accurate everyone is. Very important to get an accurate EEG interpretation, but also very accurate is to get the correct diagnosis. And so being able to recognize what is or isn't an epileptic seizure is also an important part of our training. So this is a slide taken from a talk by Dr. Wesley Kerr, who was one of my co-residents a few years ago, now a professor assistant professor at the University of Pittsburgh, who's an expert on functional seizures. And so the ILAE has this stage diagnosis model for functional seizures. Functional seizures, if you don't know, are non-epileptic events that can be very difficult to distinguish from epileptic seizures, but they require a very different treatment. And so misdiagnosis of functional seizures can be very costly both to the patient and to the healthcare system, as people don't get the correct diagnosis and they're given treatments that are ineffective and sometimes harmful. And so the key point here is that to really get to an accurate diagnosis of functional seizures, you really need a seizure physician, somebody who's been trained in this to make the determination. And so on the right-hand side here, you see the kind of relative or the rough percent accuracy of making the diagnosis, and that's really can only be achieved with the seizure physician. In a similar note, this was another study that was done where videos were shown to both fellowship-trained neurologists, meaning epileptologists, as well as to senior neurologists, senior neurology residents, and those two groups were asked to make a determination whether the video they were watching was a epileptic or non-epileptic seizure. And so the accuracy, and on the left-hand side, you see the test characteristics here comparing the accuracy, the sensitivity, the specificity of both of these groups of people. And so you can see that the fellowship-trained video watchers were much more accurate in making the correct diagnosis compared to those without that fellowship training. Again, underscoring the importance and the value of our training. Because what we do during our 1 or 2 years of additional training is we see hundreds of people with epilepsy with different types of seizures with very uncommon presentations, and we become really familiar with things, aspects of the history or the presentation that are more or less consistent with epilepsy. And so just seeing a lot of different people here, hearing a lot of different stories really helps us understand the diagnosis that we're working with. This is another similar study where again videos were shown to these different categories of providers, and the accuracy numbers are just listed down the right, where again epileptologists are just far more accurate than any other type of provider in making the correct diagnosis. What I thought was really interesting here is that the emergency nurses actually outperform the emergency physicians. And I wonder if that's because the emergency nurses are probably seeing a lot more of these events because they're at the bedside compared to the emergency physician. So it's really just a matter of seeing and meeting and seeing these things firsthand. Another reason why epilepsy fellowship training is important is expertise in anti-seizure medication management. So, as you, I'm sure, are aware, there are many, many seizure medications on the market, and there are a lot of great talks and representatives today who can go into more detail about all these different options. And I have here a slide showing all of the different options that have been available over the years, going all the way back to the 1850s when we had bromides, and only bromides, and to today when we have, just even in the last few years, several new options come available on the market. What this is meant to say is that there are a lot of different treatment paths, a lot of different combinations of treatments available, and it's very difficult to be very familiar with and well-versed in what all of these different drugs have to offer. Epilepsy fellowship gives us a lot of exposure to these drugs, to the patients that are taking these drugs. We become intimately familiar with their side effects, with their indications, their contraindications, with their interactions, not just with other seizure medicines, but other medicines for other medical conditions that the patient may have. So we're very comfortable managing these medications, and including the newest ones as well. So one of the kind of values of our training is to become experts in the prescription and management of these very, very important medications. And then the next point that I think is very important is bridging between the pediatric and adult worlds. So especially most epilepsy fellows all will do their training at a specialized epilepsy center, so that's a level 3 or 4 epilepsy center. That typically is a referral center for both pediatric and adult patients. And because we work with both of those populations, we have a very good sense or a close sense of how the impact of transitioning a patient from the pediatric neurology world that they're used to the adult world. And so seeing patients on both sides of that transition, we can really get a better understanding of the needs of that population and how to help make that transition go more smoothly. Another very important part, and I think maybe the bulk of what we spend learning and researching is the higher level skills, so the surgical epilepsy evaluation, for example. So when medicines don't work to control your seizures, the next step is often an epilepsy surgery evaluation. And in order to perform a successful and comprehensive epilepsy surgery evaluation, a lot of advanced diagnostics are needed. So some of them are listed on this slide. The most commonly used studies that we're exposed to are listed here. So, you have EEG, you have your MRI, you have your functional MRI, you have your PET, your MEG, your SPECT, all these different letters and combinations. All these different tests have their own unique strengths and weaknesses. They have types of epilepsy that they work better or less well for. Some of them are more supported by research, others are less supported by research or newer. And so all of these unique attributes are things that we learned during our training to understand how do we put all these pieces of the puzzle together to come up with the best plan for our patients. How do we know which pieces of data to put more or less weight on based on what we know about the technology, what we know about the patient. And as you can imagine, this all requires a lot of time, a lot of study, and a lot of kind of seeing patients to really understand the decisions that we're making and how to make the best one. And then another kind of offshoot of that is, a lot of patients who do undergo the epilepsy surgery evaluation will end up receiving a neuromodulation device. So whether there's currently 3 major ones, so the VNS, the RNS, and the DBS devices. And I won't go into too many details on these modalities because I know there are other talks that are focused more on that, but this is just to say that the more and more we implant these devices and use these devices, the more there will be a need to manage them. And a lot of general neurologists won't necessarily feel comfortable managing, especially some of the more complex devices like the DBS or the RNS. So a large portion of our training is devoted to understanding, how do these devices work and how can they be programmed in the best way to control seizures and improve quality of life. And then the last part of what makes epilepsy fellowship training important is really becoming familiar with resources for patients. So like I mentioned, we work in the level 3 and 4 epilepsy centers, which have concentrated a lot of these different resources that work together to deliver the best care for our patients. So for example, a lot of centers will have a dedicated social worker or case manager who's familiar with the unique needs of epilepsy patients or the unique challenges that they face. And I learned so much from working with my social work and case management colleagues. They often have more time to talk to the patient and might get information that I don't get from the patient in my 20-minute visit. So for example, a patient, and this comes mostly from the adult world, with our veteran patients, a patient might be losing his housing, and so might not have a reliable address to receive medications mailed to. And that affects kind of how I go forward with my treatment plan. Our specialized pharmacy programs, most centers will have a program that helps kind of make sure that prescriptions are ordered, they're refilled, if prior authorization is needed for insurance approval to help pay for the medications, if that's gone through without a hiccup. These specialized pharmacy programs are wonderful for logistics and making sure patients have what they need, but they're also staffed by very knowledgeable neuropharmacists who are experts on these seizure medications, who know more than anyone else some of the peculiarities and features of the medicines we prescribe. So I always learn, every week in clinic, I learn from my neuropharmacology or neuropharmacy colleagues about some of the medicines we use, and they're an extremely important addition to the care of epilepsy patients, but they're also a really great part of my training and other epilepsy fellows training because they teach us what otherwise we wouldn't learn. Epilepsy nurses are wonderful. So Natalia Tian is our nurse at the West LA VA. She knows our patients exceptionally well. She's known many of them for many years, and she knows firsthand. She's the first line of contact for our clinic, so she talks to them, on a weekly basis sometimes, and knows their unique needs, knows what their seizures do to them from a day-to-day standpoint and from a quality of life standpoint, and her expertise and her experience is so valuable, both for our patients and for my training and learning. Neuropsychiatrists and neuropsychologists are specialists who not only provide diagnosis, so diagnosing comorbidities that our patients might have, such as memory problems, attention, executive functioning problems, but they also can provide specialized therapies. So that's therapies that are aimed at treating some of those cognitive comorbidities I mentioned, but also specialized therapies for treating things like functional seizures or non-epileptic seizures. They can have specialized, for example, cognitive behavioral therapy programs aimed at helping patients work through some of the functional seizure triggers that they have. Another very important benefit of being seen at an epilepsy center would be the clinical trials. So often the newest medications, the newest surgeries and devices are being debuted at these large referral centers. And so we're always learning about what research is being done, what clinical trials are being done, both as fellows and patients. So that's also a very important aspect of our training. And I mentioned a little bit earlier the Peds to Adult Transitioning Program. So again, when patients are sort of transitioning from that pediatric epileptology to adult epileptology world, that process can be a little bit bumpy sometimes, and it's challenging for everyone, for a lot of organizations. But being at an epilepsy center, you really have more support and resources and tools to help you make that transition. And then one of the really biggest educational components and one of the most valuable elements of the Epilepsy Center is the Multidisciplinary Surgical Conference. So that happens on a recurring basis, and it's a forum where a bunch of different epilepsy specialists get together and discuss patients and discuss the best care for them. So that would be your epileptologist, your neurosurgeon, your neuroradiologist, your neuropsychologist, everyone who's been working with these patients, meeting them, helping make the diagnosis, discusses kind of how they see things from their perspective, and together we come up with a treatment plan. And it's a very wonderful experience to be a part of, because you really hear from everyone's expertise, and you learn a lot at these conferences. And then very briefly, genetic testing and counseling is typically only available through some of the larger centers. Most physicians can order genetic testing, but I think that the counseling and really interpreting the results correctly and knowing what tests to order and when is something that does require a geneticist. And more. Each epilepsy center is unique and has a unique mix of resources and a unique mix of people, and so there are lots of opportunities for learning and for helping patients at these institutions. So that wraps up the first part of my talk on more of the details of what we do as epilepsy fellows and why is our training important. Why is it important kind of for you to see somebody with this fellowship training? The second part of my talk focuses a little more on the delivery of epilepsy care in the U.S. So starting with these levels that I've been talking about. So what are the different levels of epilepsy care? And so these levels were designated by the National Association of Epilepsy Centers, NAEC, and they actually have a booth here today. And we'll be talking more about, in detail about these different levels. But in a nutshell, these levels come from a guideline that was developed by them about 13 years ago, where level 1 is really the first line providers for seizures. So if someone has a first time seizure, they're most likely going to be seen in the emergency room, sometimes through their primary care doctor after, they maybe days after their seizure. That next level, or level 2, is a general neurologist, who's somebody who is trained in managing seizures and can provide that next level of care. And then levels 3 and 4 are what's called specialized epilepsy centers that have some of those resources that I've been talking about on previous slides. And so the definition of a specialized epilepsy center is a program that not only provides routine care to individuals with seizures or epilepsy, but also specializes in providing comprehensive diagnostic and treatment services to individuals with uncontrolled seizures. So again, important to note here that it's not just those really higher level advanced comprehensive diagnostic and treatment techniques that are provided, but routine care is also provided at specialized epilepsy centers. So here is a map of all of the level 3 and 4 centers in California. There's 23 total. We're very fortunate to, in Southern California here, to have 12 centers, and many of them are represented here today. So that would be the place where you would receive that next level of epilepsy care after general neurology. Here's another diagram to kind of help orient you to when you would maybe see or be referred to some of those levels of care. This was, again, from that guideline released 13 years ago, where at the very top here, someone experiences a seizure. And again, first they're seen in the emergency room or by their primary care doctor.
They may be referred right away to a neurologist. According to this diagram, they actually may attempt to control the seizures at that level 1 level for 3 months, and if they're successful, then that's the highest level the patient needs. But if they're not successful in controlling the seizures, that's what prompts the referral to neurology. I would say in current practice, and especially in the practice settings I've worked in, that's really not the case anymore. If somebody has a first-time seizure, they really are referred to a neurologist, a general neurologist, usually right away. Without waiting that 3-month period to see if the primary care doctor can achieve seizure control. And I think part of that might have to do with just recognizing the importance of early and immediate, seizure control. Being able to achieve seizure control as soon as possible is an important goal of seizure management. The next kind of part of the diagram shows that here towards the bottom, once you've been referred to a neurologist, there's a sort of a 12-month recommendation of seeing if seizures can be controlled with the general neurologist before referring to a specialized epilepsy center. I would say this is also a little bit outdated in practice. We really encourage the referral to a specialized epilepsy center as soon as 2 medications haven't worked. So the definition of medically refractory epilepsy is the failure of 2 or more appropriately dosed medications to control seizures. You don't have to wait 12 months for that failure to occur. As soon as you know that 2 medicines haven't worked at appropriate doses, you should be referring that patient to a specialized epilepsy center. And as the patient, from your perspective, I think a lot of people don't know this when they see their neurologist. It's really important to get that referral to an epilepsy center right away when there's a sign that the medications aren't working, because we can help determine whether the diagnosis is correct and whether the treatment plan is correct. And then here is a similar indications for referring pediatric patients. So this is again from the same guideline from 13 years ago. The failure of 2 to 3 appropriate medications is explicitly mentioned for the pediatric patients as a reason to refer to a specialized epilepsy center. And then also, similarly, if you achieve seizure control but with disabling side effects of medications, that would be another reason to refer, and just to get a second opinion on the treatment plan. Or if you have a childhood epilepsy that cannot be clearly classified into an electroclinical syndrome. So back to kind of the overall outline. Next I want to talk about the VA system of the Epilepsy Centers of Excellence. So this is a system that I'm very familiar with and do a lot of my fellowship training in. So the VA ECOE network is a network of 17 sites which provide epilepsy care to veterans who served in active duty. It also, it's not just the sites themselves, but it's actually a nationwide consortium of epilepsy providers, doctors, nurses, therapists, all the specialists we've been talking about, who work together kind of at a national level to help improve the delivery of epilepsy care to veterans. The ECOE centers are also linked with polytrauma centers, so a large part of the epilepsy population we see at the VA are patients with traumatic brain injury or TBI who ultimately end up developing post-traumatic epilepsy. And so we have really good resources for veterans who can get plugged in both in the polytrauma clinics to help manage the sequelae of their brain injury, as well as the ECOE system to manage their seizures. Here's a map of the VA Centers of Excellence. So as you can see, there's 17 bubbles around the country. Ours is going to be the West Los Angeles VA. So I'll show you a little bit more about our center in particular. So this is a photo of our hospital, and there we see seizure patients in 3 different clinics. So we have the general neurology clinic, who might see the more stable seizure patients, or who have other comorbidities, for instance, strokes or headaches or other diagnoses that a general neurologist might need to manage. We also have our dedicated seizure clinic 1 day a week that's staffed by epilepsy-trained physicians and also has a neurophysiology fellow attending. Then finally we have our epilepsy clinic once a week, and so this one, also staffed by epilepsy physicians, is really focused on patients with the medically refractory epilepsy or those with the neurostimulators who might require advanced programming, or patients who have received surgery or otherwise require a higher level of subspecialty care. We also see patients in the hospital, not just in the clinic. Typically, our medically refractory epilepsy patients will undergo a pre-surgical evaluation in our EMU, or Epilepsy Monitoring Unit. So we have 3 phases. Phase 1 would be the video EEG. Phase 2 would be the intracranial video EEG. And then phase 3 is surgery. So we provide all 3 of those levels of service within our hospital and have been doing so for many years, and it's a really great team. And so speaking of the team, I have everyone listed out here who's currently a part of our 2023-2024 academic year. We've got a really great team. These people are passionate about what they do, they're fun to work with, they're extraordinarily smart and good at what they do, and several of them are here today. You can check out our booth that's just across the hall here, listed under ECOE in the program, and especially our neuropharmacists are the ones who are most represented here today. They're a fountain of information about all the different medicines available, so make sure if you have any medicine related question, please stop by and chat with them. They love to share their knowledge. And that's the end of my talk. Does anyone have any questions or anything that you wanted to talk about more?
So you were talking about if there's 2 or more failed medications being referred to an epilepsy center. We've had to fail several medications, and one of the epilepsy centers that level 4 that you talk about is Children's in San Diego, and we have a lot of experience there. So is this information about the failing 2 or more medications being directed towards the children's or these hospitals as well? Because this is surprising to me that he's had seizures since he was 2, and this is the first time I've heard of it.
Yeah, so that's a great question, and it's definitely, there's been more of a push towards that earlier referral in the last few years. And I do think that there's a big disconnect where there's, and I didn't include studies in this presentation, but there's a lot of studies that have shown there's a really long delay to referral to surgery centers and ultimately to epilepsy surgery in a lot of people in the country. It creates a lot of missed opportunities and a lot of kind of years of additional disability and seizure burden that may have been preventable if people had been referred to epilepsy centers earlier. So that is something that our field, epileptologists in general, are trying to advertise more and talk more about, especially in the last few years, really get the word out there that these referrals need to happen sooner. And I think actually Dr. Stern is, and one of his colleagues is giving a talk on that exact topic during this symposium. I can't remember exactly when it is. But yeah, that concept of referral to surgery might be sooner than you think is a theme that keeps popping up. But that's a great question, yeah.
So the same thing happened with us, but we live in New Mexico, and we go to Colorado for all of our services because we didn't get nowhere in New Mexico. So the similar thing happened to us.
Yeah, and that's.
I'm surprised you have the VA there showing about the hospital. UNM is horrible.
We're really trying to get the message out there that, once 2 medicines don't work, it's appropriate to start talking about surgery, or at least referring to a center that can help figure out if the diagnosis is correct and if the medications are correct. But yeah, that's the recent guideline, and that's based on the data that once you've failed 2 medicines, the chances that a 3rd medicine will be effective are much, much lower. So it's sort of, the idea is let's not waste time trying something that probably won't work, and let's have a parallel plan in place to move forward with surgery or other treatments, because those are more likely to be effective.
Yeah, to me, it's because Riggs Children's is the level 4 center, but we didn't make it from our neurologist to the level 4 center. Yeah, it's okay. Anyway, I kind of stopped.
Thank you for your question. Any other questions? All right, well, thank you all so much for coming. It was my pleasure to speak today, and feel free to flag me down at the end if you have any other questions. I'll just be hovering around here. Thank you so much.